I'm audible and visible. Can I just get a quick thumbs up from all my students if my audio video is fine? Can I get a quick thumbs up from all my dear students if my audio video is fine? So welcome in this session of dermatology with me, Dr. Chesta Aggarwal, your NEET PG educator on the best online platform, that is Unacademy. Now, we have some important things to be discussed with all of you, and yes, here are some of the important points. So we are having a lot of free live test for this month, so I would be requesting all of you to kindly get yourself kindly get yourself enrolled on these sessions. The next is we have planned for a mock test which have already happened in the last month, or the first day of this month, that is on May 1st. Now these are the 4 type of subscriptions which we have. So just give me a second. Yes, you can use a code that is Chesta10 to get yourself enrolled in any of these subscription. It can be Plus, Iconic, Light and MBBS first year. Plus subscription give you an access to the live classes of Unacademy. The Iconic give you an access to the subscription of Unacademy as well as Prep Ladder. Now what is there in Light subscription? You can have an access to the MCQs or the question bank of Unacademy. I hope my audio video is clear. Can I get a quick thumbs up from everyone if my audio video is clear? And the MBBS first year subscription is for those who want to get themselves enrolled in the first year batch, which will help you clear your doubts with respect to your final year university exams or with respect to the next pattern examination. Now this was for enrolling into this, you need a code, and the code is Chesta10. This will give you 10% additional discount, and this was the Light subscription which we have discussed just now. Plus is the access to Unacademy, and Iconic is an access to Unacademy and Prep Ladder. We also have NEET PG PYQ. You can use my code to access the PYQ bank, that is previous year MCQ bank. Then we have auto daily test papers, that is if you are already enrolled to Unacademy, you can give this paper after the end of your live class. Now we have a batch which was recently started, and actually this is a need of an hour, and that is called as batch on frequently forgotten volatile topics and emergency medicines. So here the topics which are very important for the exams but they are very volatile, these are discussed in detail. The batch have already started on 4th of May and this is of 10 days. I would request all my students to kindly be a part of it. So that's it for the today's session. Let us start with the first question of the today's class. And this is the first question. It will be a rapid revision session, so please answer all these questions. Shefali, Dr. Gama, Sujit, welcome all of you. It will be in half an hour session, so I would be requesting all of you to be live for the next 30 minutes. The question is, a man presented with a history of diabetes, alcoholism, with chronic suppurative nodules, granular bodies on light microscopy, and on doing the culture we can see Staphylococcus aureus colonies. What will be the clinical term you will use to describe this type of infectious lesion? I want all of you to please answer this question. Very nice, all of you. The correct answer of this question is option number 1. Now what is Botryomycosis? It sounds like a fungal infection, but it is actually a bacterial infection which occurs secondary to Staphylococcus. The answer is not rhinoscleroderma. Please remember, I can see a lot of you marking option number C as the answer. That is not correct. The presence of mycetoma-like lesion, but on doing a culture you see Staphylococcus. It's a very classical description of Botryomycosis, which is a bacterial infection. It is neither scrofuloderma. What is scrofuloderma, Priyanka? Scrofuloderma is a TB infection. Mycobacterial tuberculosis is the organism. So how come Staphylococcus colonies you are seeing? Same thing, rhinoscleroma and ecthyma gangrenosum, they are not very classical, which is seen here in these individuals. I hope I am audible and visible to all of you. Is there any lag in the audio video? Is there any lag in the audio video? The next question is on your computer screen. Causes of erythema multiforme except chronic renal failure, systemic lupus erythematosus, mycoplasma or herpes simplex infection. All are the causes of erythema multiforme except. So what is the correct answer? Chronic renal failure, SLE, mycoplasma or herpes simplex infection. I hope you all know what is erythema multiforme. In erythema multiforme, you see a very classical target lesion. You see a very classical target lesion where you have three zones: a central necrotic zone, a middle edematous zone, and an outermost erythematous zone. So in which of the following condition you see these three zones? That is the answer. In which of the following condition you see these three zones? Anyone can tell me the answer. Very nice, all of you. The correct answer of this question is, you see erythema multiforme in SLE, you see erythema multiforme in mycoplasma, and you see erythema multiforme secondary to herpes simplex infection. But you never see erythema multiforme secondary to chronic renal failure. Please remember, that is an incorrect statement. In SLE, you see erythema multiforme, and this type of lesion is known as what? This type of lesion is known as Rowell's syndrome. This is known as Rowell syndrome. Let's move to the next question. The HLA associated with carbamazepine induced drug reaction would be. The HLA associated with carbamazepine induced drug reaction. What is the answer here? HLA B5701, HLA B5801, HLA B102 and HLA CW6. Which of the following HLA is associated with carbamazepine induced drug reaction? Which of the following is associated with carbamazepine induced drug reaction? Very nice. The correct answer of this question is option number 3. Now, what is the significance of this presence of HLA? First of all, remember that it is more common in Asian population. And those who have presence of this HLA, they have more risk of having carbamazepine induced drug reaction, like Stevens-Johnson syndrome or toxic epidermal necrolysis. Severe form of drug reactions are more frequent in those individuals which have the HLA 1502 present in them. So it is always advised to have a HLA level done before starting a patient on carbamazepine. And if this comes positive, you have to give a completely different drug. We usually prefer giving sodium valproate, because even phenytoin or other antipsychotic drugs or anti-epileptic drugs like as I already said, phenobarbital or carbamazepine, they all causes the effect like Stevens-Johnson and toxic epidermal necrolysis. Now, can you tell me in which of the dermatological condition HLA-CW6 is involved? Anyone can tell me the answer. Please remember, HLA-CW6 is a feature of psoriasis, and specifically the cuttate type of psoriasis. Okay, and 5701 and 5801, this is also important, and I want you to tell me which drug is associated. I am giving you a hint. You have to tell me this in the tomorrow's session. This is an homework for all of you. Very important that in HLA B5701 and B5801, which drugs are implicated. Next question is on your computer screen. The recently trial medication of basal cell carcinoma, crisaborole, Apremilast, Vismodegib or Brodalumab. Recently trial drug for basal cell carcinoma. Very nice. Now please remember, in basal cell carcinoma we have seen that sonic hedgehog pathway play a very important role. Sonic hedgehog pathway plays a very important role, and that is why we have few drugs like Vismodegib and Sonidegib. We have Vismodegib and Sonidegib, which are sonic hedgehog pathway inhibitors, and they work very well with respect to basal cell carcinoma. Now these are the drugs, but what is the treatment of choice for basal cell carcinoma? Please remember, it is never the drug. The treatment of choice is always surgical removal. Surgical removal, and a very specific surgery we do here is microscopic Mohs surgery. We do a very classical surgery which preserve the maximum tissue possible, because you see the lesions of basal cell carcinoma more on the face. Now my question is, what is Brodalumab and where do you use it? Brodalumab is IL-17 receptor blocker, and it is used, or it's a very useful drug in the patients of psoriasis. Crisaborole is a phosphodiesterase inhibitor which is used as a topical drug in atopic dermatitis. And Apremilast is again phosphodiesterase inhibitor which has multiple uses, but we use commonly in psoriasis, alopecia areata, and even in few cases of vitiligo. So please remember, all these four options can be a potential question in the next exam. So you need to know what are these new drugs and how they work. Can I get a quick thumbs up if this point is clear? Clear? Next. Most common neurological tumor associated with neurofibromatosis type 2. Neurofibromatosis type 2, the most common neurological tumor associated. Very nice, Benedict, Gamma, Adil. The correct answer of this question is acoustic neuroma. Now there are two neurofibromas which we have to discuss, or we need to know more in detail. One is NF1 and another is neurofibromatosis type 2. Now few questions which was asked in the past: which chromosome defect or which gene defect? It is chromosome number 17, and neurofibromatosis type 2 is chromosome number 22. Cutaneous lesions are mainly seen in NF1, and what are them? They are cafe au lait macule, neurofibromas. There should be more than equals to 6 cafe au lait macule, more than equals to 2 neurofibromas. Then they can have lesions in the iris leash nodule, and they can have what is called as multiple freckles in the flexures known as axillary freckling. In addition to all these features, they have what is called as sphenoid bone defect and optic gliomas. So optic glioma is actually a feature of neurofibromatosis 1, not 2. While in NF2, the cutaneous lesions are not seen. The only thing which is very prominent is acoustic neuroma. So please remember, they sometimes ask you the questions on NF2 as well, although NF1 is more important, and I have already discussed what are the cutaneous features of them. Follicular hyperkeratosis is related to the deficiency of. Follicular hyperkeratosis is related to the deficiency of. Meningiomas are not very common with neurofibromas, Priyanka. It's not very common with neurofibromas. I hope my audio video is fine, or is there any gap between the audio video? Is there any problem with the connection? Yes or no? Please give me a quick thumbs up if everything is fine. Now, follicular hyperkeratosis is related to the deficiency of, the correct answer is vitamin A. And if you have remembered, in vitamin A, in these individuals, the initial feature is dryness, ichthyosis. Skin will become lusterless, followed by a very characteristic follicular hyperkeratosis of the extensor area, which is known as phrinoderma, popularly known as taut skin. Popularly known as taut skin. So phrinoderma and the taut skin, it's a feature of vitamin A deficiency. Now what happens when zinc deficiency occurs? Zinc deficiency usually occurs at the time of weaning. When the baby is weaned on the top feed, or when the mother's milk is reduced and the patient is kept on the top feed at the time of weaning, and they will characteristically develop what is called as acrodermatitis enteropathica. Acrodermatitis enteropathica with a very classical DAD features, that is diarrhea, alopecia, and there is periorificial dermatitis. Diarrhea, alopecia, and there is perifollicular or periorificial, that is around the mouth or around the lower extremity, periorificial eczemas. Clear all of you? What is vitamin C deficiency causes? Vitamin C deficiency causes what is known as scurvy. Patient will present with perifollicular hemorrhages, recurrent bruises, spontaneous bruises. So please remember, these are some of the features which you need to know with respect to follicular hyperkeratosis. That is, vitamin A causes this condition. Next question, identify this test. The next question is on your computer screen. Please tell me the answer. Identify the test. Prick test, contact dermatitis, patch test. Anyone? Pathology test. Prick test, contact dermatitis, patch test, contact dermatitis, pathology test, basic disease, or pathology test, pyoderma gangrenosum. The correct answer of this question is very clear. Option number 2. It's a very classical image of what is called as a patch test. Now look at this. This is the upper back of the patient. Can you see the upper back of the patient? You have 4 strips. These are micropore, and if you see at the center, these are the aluminium disc, which is known as fin chambers. Fin chambers. These are the hypoallergenic aluminium chambers. Fin chambers. Okay. Now we have in market, we get Indian series of allergen. So by doing multiple studies, we have found out that there are total 20 allergens which are very common in our Indian population, which is responsible for causing most of the allergic contact dermatitis. So we get the pre-filled syringes of these allergens in the market. Now with the help of these pre-filled syringes, what we do, we fill each fin chamber with a separate allergen and we will stick it on the upper back of the patient. We will call the patient after 48 hours, that is on day 2, and we will remove this patch. And then we will call the patient on day 4, that is after 96 hours, and then we will read it. So that is how the patch test is done. Please remember, it is the investigation of choice for allergic contact dermatitis. And it is based on type 4 hypersensitivity reaction, which is also known as delayed type of hypersensitivity reaction. Type 4 hypersensitivity or delayed type of hypersensitivity reaction. We do the test on day 0. We ask the patient to come on day 2, that is 48 hours. And we will remove the patch on day 4. This is day. that is 96 hours. This is a previous year AIMS question. So please remember, you get these type of questions in your exam, and that is why I am compiling everything and giving you the answer of this question. Very nice. So I think nobody has any confusion with this. The next question is on your computer screen. Please tell me the answer of the next question. Gaurav, Gamanaif, Arjun, Benedict, Vikram, Adil, Shrujan, everybody is right for this. The patch presents with an eczematous, a patient presented with the eczematous rash on his wrist in gel and Coombe classification of hypersensitivity. This is an example of, very interesting actually. So we have just now discussed, I should not have discussed this question in the last one. But anyways, I think now you got the hint why we have discussed that what type of hypersensitivity reaction is this. First of all, tell me what is the diagnosis of the patient. If somebody comes to you with these features, how will you diagnose and what is the reason behind this? Anyone? Very nice. This is a patient with allergic contact dermatitis around the wrist. Now around the wrist, they can be because of bangle or it can be because of watch straps or because of metallic dial of the watch. The most common cause of or the most common allergen present in both of them is nickel. It is a common adulterant in the bangles or in any jewelry, whether it is gold, because in gold it is a very malleable metal. We need to add something in the gold so that it becomes hard. So we add nickel in the jewelries to make it little harder. And we have just now discussed that allergic contact dermatitis, it's a type 4 or delayed type of hypersensitivity reaction, and that is why the correct answer of this question becomes option number 2. Is this clear? Can I get a quick thumbs up from everyone? Next question is on your screen. Hartog sign is a feature of. Hartog sign is a feature of. Hartog sign is a feature of. Very nice. Atopic dermatitis, hypothyroidism, leprosy, all of the above. The answer is all of the above. Now the question is, what is Hartog sign? Hartog sign means loss of lateral 1/3 of the eyebrows. Loss of lateral 1/3 of the eyebrows is the Hartog sign. You see them in atopic dermatitis, where it is very popularly known as Queen NA sign. In leprosy, they are usually called as madarosis. And in hypothyroidism, we simply call it as Hartog sign. So please remember, this is not only specific to atopic dermatitis or leprosy or hypothyroidism. You can see them in multiple conditions. Pityriasis alba is a feature of. That's a very simple one-liner question, but let's see how many of you can answer. What is the correct answer of this question? Pityriasis alba is a feature of psoriasis, pityriasis rosea, atopic dermatitis or pemphigus vulgaris. What is the correct answer? Shrujan, Arjun, Dr. Kama, Benedict, Adil, Vikram. Very nice. I'm getting the answers already. Please think and tell me the answer. Pityriasis alba is one of the minor criteria of atopic dermatitis. Now, atopic dermatitis, it's a pure clinical diagnosis, and we use a criteria which is known as Rutschkas and Hanifin criteria. It's a pure clinical diagnosis. It's a pure clinical diagnosis, and we use Rutschkas and Hanifin's criteria. Clear? Rutschkas and Hanifin's criteria. Now, the major criteria includes presence of itching, chronicity of the disease, presence of itching, chronicity. What is third? Classical feature like infantile stage, the adult or childhood stage, classical features, clinical features. And fourth is associated family history of atopy. Minor criteria, we have a lot of minor criteria like Denny-Morgan fold, ichthyosis or dryness of the skin, ichthyosis or the dryness of skin. What else we have here? The minor criteria, we have hyperlinearity of the palmoplantar skin. Then we have what is called as pityriasis alba. This is a hypopigmented ill-defined lesion on the face. What else we have in these individuals? We have recurrent skin infections. We have ocular features in the form of keratoconus, anterior subcapsular cataract. Then we have madarosis, hyper IgE response. So these are some of the features which I have mentioned here. There are many more minor criteria, but please remember it's a feature of pityriasis alba. Atopic dermatitis. True about Pomfalix is all except. Please tell me the correct answer. Please tell me the correct answer. True about Pomfalix is itchy lesions on the palm, potent topical steroids associated with anhidrosis or painful deep-seated lesions. Anyone? Tall, Shrujan, Shubham, Dr. Kama Naif, Adil, then Arjun. The correct answer of this question is option number 3. Please remember that Pomfalix, it is a disease which is also known as dyshydrotic dermatitis. It's a condition which is also known as dyshydrotic dermatitis. And why do you develop this? Because of increase in sweating. So associated anhidrosis is not a feature of Pomfalix. So the correct or the statement which is not correct here would be option number 3. Itchy lesions on the palm, this is absolutely true. Potent topical steroids are the treatment, that is again true. And deep-seated vesicles, which is like a sago grain, sabudana, sago grain like. Have you ever seen the sabudana kheer or boiled sago grain? It becomes transparent. They become transparent when you boil the sago grains or sabudana. So that is what is a very characteristic feature of this patient's condition. With this, we are done with today's session. I hope everyone have enjoyed this. Thank you all of you for watching this amazing session. Now we will be taking these sessions every alternate day on the same time, that is 2:30 p.m. Now at 3:30 p.m. I will be taking a live special class, which is a free class on the app. So please download the Unacademy Learning app and watch my session live at 3 p.m. You might need a code to unlock these class, and this is my code. This code will also give you 10% discount on any of the Unacademy subscription. Don't forget to subscribe this YouTube channel. We also have a Telegram group with the same name. Press the bell icon to get all the notifications of my classes, and please don't forget to give me a thumbs up so that we can make more interesting videos like that. So bye bye all of you.